Hey guys, Chris here from Lifeline EMS Training. Today we're going to go over heart failure, a tale of two pumpers. So, when we're talking about heart failure, failure is not really an option, right? So, we have complete heart failure, we have cardiac arrest, which we'll cover in another video. But when we're talking about heart failure, we have to do a revisit of the anatomy and physiology. So, we look here at the right atria. Right atria takes deoxygenated blood down to the right ventricle. Right ventricle gives it out to the pulmonary artery to the lungs. The lungs help oxygenate it through the capillary beds of the alveoli. Return it back to the left atria. Now it's oxygenated down to the left ventricle out to the body. And as we see here, the ventricles are bigger than the atria. They're also structurally different, a little more dense muscle. Atria are auricles, so they're kind of a little more floppy. They have the ability to stretch, which we'll talk about in a bit. That stretch or that over-engorgement or that overfilling helps release peptides, which trigger urination and regulation of fluid. So it also helps with fluid regulation because if they're becoming overfilled or overengorged, the body wants to reduce that pressure and volume back into those chambers. So here we have the vena cava, which gets absolutely no love. And you'll find if you watch a bunch of our videos, we try and give it the highlight that it deserves through respiration and return back to the right ventricle. So it's the vena cava that actually starts the whole heart circulation process. So that's like the fire hydrant and hose to the fire truck, if you will. So deoxygenated blood comes back from the superior and inferior vena cava to the right atria. Right atria feeds right ventricle feeds the lungs. That oxygenates to the left atria, which feeds the left ventricle feeds the body, goes up and out to the body. So let's talk about how the heart is like a fire truck. Most people know fire trucks, especially little kids. So we have fire hydrant and the supply line here. This would be in the pump operator world, the static water supply. So this would be both volume and pressure you'd be concerned about getting to your heart or your pumper. So this would be the vena cava and the volume of the body. And then you have your heart here. So you have RPMs. So you have an impeller inside of here which spins and has little fins that kind of slam to the wall and help push and drive water up and out of the system. Pump discharges out to the hose. The hose size is selected by the firefighter, and then out the nozzle. So nozzle pressure uh, right here. And you have pump discharge pressure, which technically comes out of here, but the discharge pressure coming out of the pump to the hose out to the nozzle. There's a lot of similarities with this too, right? We have friction loss here, depending on the size of the tube, depends on how much of that water column meets resistance on the side of the hose. That's no different than vascular resistance. Systemic vascular resistance, depending on the size of the tubes in the body, has friction loss, if you will, or resistance, where the water column or the blood in contact with the wall actually has resistance. So it has almost like a shearing force, if you will. So the couple things the pumper can't do that the body can do, and specifically in this instance, the heart can do is contract, right? It doesn't have that Starling effect. It's not like the pump on the pumper can expand and contract, expand and contract. It can only throttle up or throttle down its RPMs. Now, the pump operator can gate or regulate the size of the orifice that the fluid is coming out of the pump to the hose. But really, the body can do that too through vascular regulation. And so the other thing that the pumper can't do is select the size of the hose. The firefighter pulls the hose, and the pump operator has to calculate that math based on that. The body can regulate the size of the arteries and veins depending on the pressure reception in the carotid bodies and aortic arch. So the body is much more advanced than the fire truck. But if you think about static water supply, so vena cava, this is gallons per minute, and PSI. We don't get PSI from the vena cava, but we do get liters per minute. We do get volume. We have RPMs of the pump, so this would be like the pulse. We don't get contractility of the pumper. We do with our heart. We don't get vascular regulation with our heart. I'm sorry, with the pumper, but we do with our heart. So there's a lot of similarities. And then again, the water going on the fire, blood going out to the body. So let's talk about the right side of the house or right-sided heart failure. So we have the vena cava, comes up, feeds into the right atria. Right atria feeds into the right ventricle, which in this case we're going to call our right blue pumper. And then that blood flow goes up the pulmonary artery into the lungs. And so its job or its dependence is on venous return to the right atria. Right atria given that little 20% atrial kick poof, to fill the right ventricle, and right ventricle giving blood flow to the lungs. Hopefully, the lungs are functioning well, have good capillary flow, limited resistance, and it's easy for the ventricle to disperse blood up into those lungs so that they can go through the capillaries with the alveoli expanding, get the gas exchange, oxygenate, and then come out on the left atrial side. Well, what happens if that pump fails? Well, if that pump fails, meaning it's, let's say, had a heart attack or something is creating high resistance in the lungs, which we'll catch on here in a second, that pump starts to fail or become damaged or become impacted, we get backup. We get backup and we get atrial stretching. So we get that right atria that starts to engorge or stretch. That can only take so much stretching. And then you get backup in your venous system. And then you get venous backup. So what does that look like, right? Well, if we get that increased, let's say in this instance, resistance of the alveoli, so the person has COPD. Right-sided heart failure is very common in patients with emphysema because their alveoli become very saggy and the capillary beds around them become very windy. And as those capillary beds become very windy, it's more resistance. So that right heart has to pump against more resistance. It becomes damaged over time. Right atria swells and engorges, vena cava backs up, and it releases atrial natriuretic peptide. And what that does is that essentially goes down to the kidneys and says, hey, pee off some volume. So that's one of the ways the body has a regulatory process in place saying, hey, we're getting too much volume here. Help us offload some of that. So that would be like a person going to the hydrant and shutting down a portion of the hydrant if this was the fire truck to reduce the amount of volume into the system. So what do you see when you see right-sided heart failure? Well, you see the right side fails. You get ascites or swelling of the belly. Part of that is because the liver, which has the portal vein, starts to engorge and swell. You see JVD. Of course, this is an extreme case here, but you see JVD, you get engorgement. A lot of times when it's early on, you'll see this really when the person breathes. So when the person breathes, the increased volume of their lungs pushes on that vena cava and it pulses the volume back up as the person's breathing in. You see edema in the legs, right? Because that vena cava swelling, increased static pressure, you get leakage. That leakage pulls down dependently based on gravity. So you see it in the legs, and then you see frequently engorgement of the distal veins in the legs, again, from that dependent gravity drop because of the back pressure not allowing good venous return. So these are some of the things you'll see with right-sided heart failure. So the key really with right-sided heart failure in our world is assessment. What caused it? Is it a heart attack that's causing it acutely right now? Is it a clot in the lung? So if a person has a pulmonary embolism in the lung and it's blocking good blood flow, that right heart, right ventricle has to pump against that increased resistance. If it has to pump against that increased resistance, especially in an older person who may or may not have some damage already, you may see an exacerbation of that and the person goes into right-sided heart failure because of this clot. You can see it in young people too. You get a big enough pulmonary embolism, that amount of resistance that that heart is pumping against, you will start to see the backup of that in the vena cava. So that could be a sign of a large pulmonary embolism. When was the onset? Oh, this has been going on for 2 years. It just gets worse. Versus this happened 2 minutes ago. Things that happen fast need to be fixed fast. Things that happen over time, we have time. So definitely want to do your EKG. Definitely want to get your vital signs like you would do on everybody, your lung sounds. Of course, with a pulmonary embolism, you're not going to hear a difference in lung sound because this is in the blood flow side, not the airflow side. And you really want to gobble up that onset and history, meaning, is this something that just started and it just happens to be the most worst today? Or is this something that's been going on for a while and yeah, today is definitely, I can't tolerate it anymore. So that's right-sided heart failure, right? There's not a lot we can do except for good quality assessment, ensuring the patient's oxygenated, comfortable, and then trying to rule in or rule out what the causation is. Left side of the house, so the part that pumps out to the body, this is the one that gets all the attention. This is the one you constantly hear is congestive heart failure, and we'll talk about where the congestive part comes from. But blood flow comes from the lungs to the left atria, which the left atria for the left ventricle is the hydrant, right? Left atria feeds the left ventricle feeds the body. So it's the pump for the body. Well, what happens if there's an issue? Well, if there's an issue, so let's say the person has chronic pulmonary hypertension. So they have really, really narrow or tight vessels in their lungs, and that's putting high pressure and volume over to the atria. Specifically, the pressure is where we get the problem. That person creates that stressor or that stretch of the left atria. It releases ANP, tells the kidneys to pee off some volume. And over time, if we constantly are hitting this with high pressure, it's going to stay engorged or become damaged. And that's commonly where you see atrial fibrillation kick in. Chronic states of high left atrial pressure excite or irritate the heart cells in the atria, and that's one of the causes of atrial fibrillation. So when the pump fails, like we were talking about, is it a heart attack? Is an acute heart attack the problem, or is this a chronic issue? So when it stretches, like we said, it releases that ANP to offload some of that volume. And our worry when we're looking at patients in congestive heart failure, and we talked about it with right side heart failure, what's the onset, right? Is this you've never had a history of heart failure before and it happened all of a sudden, or you have a history of heart failure and this is just the worst it's been and you cannot tolerate it anymore? The worry in the acute setting where it comes on very quickly, or flash pulmonary edema is what you'll commonly hear it termed as, is it a heart attack that's creating a floppy ventricle that is not able to work well, and that floppy contractility is creating the backup? Because what's happening is the blood flow from the right is exceeding the blood flow from the left. It's output, and you're creating a backup in the circuit. And those backups become problematic. Now, in the past, patient had a heart attack when they're 50s and now you're running them when they're 70s, what happens? Well, when they had that heart attack, they get the floppy heart and they have to work that wall around the area that this is clearly a picture of me, of course. The wall around that area has to work harder and harder and harder. Well, what you get is remodeling. So you get restructuring, remodeling, increased muscle density of that ventricle. And if you notice the difference in chamber sizes, so if this is given 70 milliliters for, say, just easy math, and this can only eject 30 milliliters, we have a net difference of 40 milliliters. And if we're adding more volume into a container, which in this instance is the lungs, we're going to increase pressure. Because we're giving 70, only offloading 30, we have a net difference of 40, and that 40 stays in the container of the lung blood vessels. That becomes a problem for us. The other thing is, hey, if this is that acute heart failure from the heart attack, is it just that the left ventricle is floppy because the tissue is damaged and dying? That's where you see it really in the acute setting. So in the person who has the chronic heart failure over time, you really see the remodeling of the left ventricle. And it's not something we see, it's something you would see on the echo or the x-ray. For us in the acute setting, we recognize that it's probably the ventricle's floppiness from the damage to the cardiac myocytes that don't allow them to contract well. So what happens in the lungs when you have that net difference or that backup or that high static pressure in the pulmonary capillary system? Well, these cells, these capillary or the vascular endothelium, normally stick together. They have adhesions. So they're normally plated together, just like the skin, your epithelium of your skin, endothelium inside, blood vessel, epithelium above the outside of your integumentary system. Well, when the pressure is super, super high in them, they actually get stretched, kind of like a net, and those adhesions still hold them together. But what you actually get is plasma leaking out. You'll see the big dumpy red blood cells stay behind, but the plasma leaks out until you may or may not get micro ruptures. So this plasma goes into the alveoli And when the person's breathing fast from their stressed state from this heart failure event that's put them into the acute extreme or acute extremis, they add more air at a high rate to this fluid and they get bubbling. That's where you get frothy sputum, or you get pink frothy sputum if some of the capillaries have ruptured. Capillaries don't want to rupture, but enough pressure, enough stress, they will rupture and you'll get some pink frothy sputum. So that's where they get the fluid in the lungs. So it becomes like a soaker hose almost leaking out because the pressure exceeds what the wall can retain. Other things you'll see with patients who have heart failure is orthopnea. So depending on their position, they'll actually struggle to breathe. So if they lay flat, the amount of surface area affected by the fluid in their lungs is greater than if they use gravity to their advantage. So what'll happen is they'll get more fluid that goes to the bases of the lungs versus the top if they're upright or using gravity versus if they're laying flat. Now, patients with chronic left-sided heart failure will always have fluid in their lungs. You'll always hear crackles. They'll usually be fine, except for when they're in the extreme stress states and that left ventricle is really struggling and the right ventricle is really trying to onboard a lot of volume. Then you'll see the fluid increase rapidly. And it's those states where we usually run these patients. It's usually a stressor that's created a sympathetic dump, increasing their heart rate, increasing their vascular resistance from that noradrenaline and adrenaline, dumping volume back to the heart, overflowing or overflooding the pump. And then who's the pressure blow off? The pulmonary capillaries. That's why we see them get that pulmonary edema, and then they go into a bad loop because the pulmonary edema doesn't allow oxygen to go through easily. So then they get into an hypoxic state and their body says, oh crap, I don't have enough oxygen. I need to breathe more. I need to stress out more because I need to get more oxygen. And it's just a vicious, vicious cycle. And we'll talk about how to fix that here in a second. So a couple things with the orthopnea. I've had patients before that literally sleep on the side of their bed. Like if their bed was here, they lay their head on the side of the bed because they struggle so bad if they lay flat. If you walk into a house and you see a person who has trouble breathing and they have 52 and a half pillows behind them, probably a good chance they have a history of heart failure if they're trying to sit upright like that. Because what they're trying to do is create that dependency on the edema to go down to the lower portion of the lung cavity. So how do we support them, right? They get all that fluid in their alveoli. Oxygen cannot go through. Well, CPAP or PEEP. We want to restrict their exhalation to help their alveoli get a little bit bigger to increase the oxygen exchange surface area so that the amount of alveolar surface area in contact with liquid is less. PEEP is pulmonary edema and drowning patients' friends. It helps with their oxygen exchange capacity. The better we can get them oxygenated, the better they'll get out of this loop. And so a lot of times you'll see they don't need much more than the 30% FiO2. This is a Trio Max one that you can switch to 30, 60, 90. 30 will usually do them just fine. It's adding the PEEP, giving them 5 centimeters of water, checking them, giving them 7.5 centimeters of water, checking them, giving them 10 centimeters of water, checking them. Some of these go up to 15. You want to keep an eye on that blood pressure, but in most instances, these patients have high blood pressures where their diastolics are above 100. And it's that high resting pressure that creates that static pressure in the pulmonary capillary bed that creates the volume leakage. So how do we help them with the volume overload? That's easy. Nitrates. Nitroglycerin helps dilate their vena cava so they're not being over flooded on the right side of their body. So the amount of return or volume return to their pumper is not overrunning them. And so nitrates, so 0.4 milligrams, 0.8 milligrams nitrates would go with what your protocol says. But CPAP for oxygenation, nitrates to stop the volume overrunning or overload, and then do a 12-lead EKG to make sure that this isn't an acute heart attack that's caused it. This is one that a lot of people forget in the instance. They run that chronic CHF patient that they know they're get used to running them the first name basis and they forget to do the EKG to see if, hey, why are we running this person today? It might be because they're having a heart attack and they have increased failure on that side of their heart on top of the chronic failure that's put them into this extreme condition. So I hope that helped you with heart failure. As always, if you have any questions, hit us at info@lifelineemstraining.com, and we hope you have a great day.